Uh, thank, thank you so much for joining us for today's Lunch and Learn session, which comes under the banner of the Paediatric Society of New Zealand, Te Kahui Mātai Arota Mariki o Aotearoa, and the Child Development and Disability Clinical Network. My name's Kate Waterworth, and I'm very glad to welcome and host Rebecca Barnard. So Rebecca is an occupational therapist who is a feeding specialist and the director of her company, Nourish Feeding Therapy, which is based down in Christchurch. So this is a private practice service which specialises in supporting children who experience a range of feeding challenges. So Rebecca is going to speak on paediatric feeding disorder, a new feeding disorder diagnosis and assessment. Just a reminder for those that would like to join us in 1 month's time, we have a follow-up session in which we think and talk, which is not a taught session, a conversation, but it's a conversation between those who join us to think about the implications for our practice. So that's on Tuesday, the 15th of August at midday. And I'll be the host for that again. So people that come to that, we really want to hear your ideas and suggestions and challenges. A reminder about what the Paediatric Society of New Zealand is. The Paediatric Society obviously welcomes as many members as possible. There are some changes in the moment going through in terms of how the clinical networks are going to be composed and operating, but we're looking at trying to keep the Lunch and Learn going in the interim. So now I will stop sharing these particular slides and Rebecca will just take a moment to share her own and then we'll ask her to begin speaking when she can.
To get my technology working.
There we go, that looks good.
That looks good.
Perfect. Well
okay.
Done. Thank you. So you start when you're ready, Rebecca.
It's always nice when technology works for us. Thank you for that lovely introduction. That was great. I'm so excited to be here talking about paediatric feeding disorder. I feel like for so long we were just working under this unknown umbrella of feeding challenges. We kind of knew it was paediatric feeding disorder, but it was just this umbrella term. So it's really nice to have now a set diagnosis and sort of assessment criteria. So I'll kind of just be talking us through that a little bit today. In brief, it's a very complex thing, but I'll just be doing it in brief today. Oh, there we go. So paediatric feeding disorder only became an official ICF diagnosis in 2021, in October of 2021. So prior to that, we were just working under this unknown feeding challenge and we're really sure why. But paediatric feeding disorder essentially encompasses all of the complexities of feeding, and it's defined as impaired oral intake that's not age appropriate and is associated with has to be one or more of these categories, so medical, nutritional, feeding skill, or psychosocial dysfunction. We'll go into what those areas are a little bit later, but it's quickly becoming one of the fastest and most common diagnoses that we're seeing in children. It's impacting about 1 in 23 to 1 in 37 children under 5 years of age. So it will be something that you come across in your practices, I'm sure, because it is quickly becoming very common, unfortunately. Paediatric feeding disorder, like I said, is one or more of those feeding domains, which we'll get into, but it's very clear that it's not the same and it doesn't come under the umbrella of other eating disorders. So a child is not able to eat or having difficulty eating orally, but not because of relationship to body image and not because of sort of ARFID, which we'll get into as well. So not around a fear of what the food's going to do. It's more I can't eat or there's something stopping me from eating safely. And paediatric feeding disorder, we don't have a lot of research yet in Aotearoa, but there's lots of research coming out around the impact that paediatric feeding disorder is having on children and their families. There's parents needing to leave jobs because there's children who are tube fed, or they'll only eat in a certain way, in a certain place from a certain caregiver. So there's parents needing to leave jobs, lots of mental health associated with that, and obviously an income loss to the family as well. So, like I said, it became an official diagnosis in October of 2021 under the ICF framework. It was hugely significant because I think prior to that, we've always worked under a multidisciplinary team, but it was sort of more just individual professionals treating parts of the feeding disorder rather than working under a whole team. And this Paediatric Feeding Disorder framework kind of says, well, because there's all these domains that we need to work and assess and treat, we need lots of multidisciplinary practitioners involved. So we need a whole team approach because feeding is so complex. It also created a pathway for children that were presenting with what they were calling picky eating, or they were calling fussy eating, but it was obviously significantly more than that. So what it's done is gone, yes, there is a challenge here and we need to actually address and treat the challenge rather than just going, it's just fussy eating, we'll grow out of it, or it'll be fine, just wait and see, give it a couple of years kind of thing. So it opened up a wide range of possibilities for families to actually go, no, there is a challenge here that we need to address. So there's 4 domains of pediatric feeding disorder. And like I said, they all kind of they work together, but there needs to be at least one domain compromised that's impacting feeding for it to be pediatric feeding disorder. Often though, we'll see all domains impacted when our children are presenting to us. There's very much all domains are impacted. But when we're looking at the medical piece, the main ones that we're looking at and that are seeing, hopefully we're picking them up as early as possible in our cardiorespiratory and our aspiration pneumonias and our differences that we're seeing, so cleft palates, etc. Those are hopefully being picked up as early as possible, but then we've got other things that are coming up. So reflux and any ENT obstructions are the main sort of medical pieces that we're seeing that is impacting feeding. But when it comes to the medical piece, it's essentially anything medical that is contributing to the feeling that the child is getting, that every time they eat, it hurts. Every time they eat, it's uncomfortable and it doesn't feel good. So just reiterating that food doesn't work for them, but also it doesn't feel good when they are actually eating. So sometimes what we'll see, and this is particularly in children under 18 months, is when these flags start to pop up. We will see changes in their breathing when they're eating, so either directly as they're eating or straight after. There will be lots of crying and arching and physical discomfort and the child not wanting to eat, which, as we know, under 18 months, it can't be a behaviour. So there's clearly something medical or in that feeding skill domain that we need to address. We will see signs of coughing, gagging, vomiting, choking quite frequently. In our under 6-month-olds, we'll see lots of, just breastfeeding or formula feeding didn't go well. They'll start breastfeeding, lots of vomiting. Mum will try an elimination diet, lots of vomiting. They'll then try different formulas, lots of vomiting. And it's like, well, there's clearly something there. And is again creating that story that vomiting and food is the same thing, so I'm not going to want to eat as well. We'll also see lots of chronic, or in more so our aspiration pneumonias and cardiorespiratory pieces. We'll see lots of chronic upper respiratory infections. So the rest of the family seem to be well, but this child is just always sick. There's always a cough. There's always some type of illness that they can't seem to shake. So our medical piece is quite a large one, and like I say, there's something medical in the way, and it's a nice, or has been, what I've seen from families is a nice, I guess, weight off their shoulder to go, okay, we're not just having these feeding challenges because of something that I'm doing. There's something medical. There's a reason why this child is struggling to eat. So that's sort of our first domain. We then have our nutritional domain, which kind of says there's some malnutrition. There's either the child's either overweight or underweight, having significant deficiencies, clearly a very restricted and limited diet that's lacking in diversity. Often we'll see no fruits, veggies, or proteins, or if we do the proteins, maybe chicken nuggets, and the fruits maybe in a puree pouch every now and then, not consistent. Or we'll see children who are reliant solely on enteral feeds, or who need oral supplements to support their diet because they are simply unable to eat or drink enough to grow and to stay hydrated. We then will see the constipation cycle. So it's did the constipation come first and then it contributed to the food, or did the food come first and it contributed to the constipation? But those kind of cycles are clear to us that there is some kind of nutritional dysfunction that we need to address as well. We then have the feeding skill domain, which is quite a large one, but also one that hasn't, I guess, been as researched as much. But it kind of says that there is something in the child's physical body or something that's impacting their ability to eat certain food textures. So a lot of the times they'll need, or a flag for us is they'll need texture modification. So they either need thickened fluids, or they will only have purees, or they'll only have meltable foods, or they'll only have certain textures because that's all that they can manage. Or they have to eat in a certain position. Maybe there might be a cerebral palsy or a muscular dystrophy or something else contributing to that, so they need to be in a different position, or they need certain feeding strategies. So they will only eat if there is a device in front of them, or meal times are very, very short or very, very long. In this case, we'll still often see coughing, gagging, or choking as a flag of a feeding skill dysfunction. A lot of the times our neurodiverse population kind of tend to come under this category as well. So the sensory processing challenges element of feeding is quite a large part. As we know, feeding is a sensory oral experience. So if the child is having some sensory processing challenges, that would come under our feeding skill domain. So obviously, a lot of the times we're seeing our autistic and ADHD children who are presenting with these sensory processing challenges, which means that they simply can't manage these more complex textures of food, or, it looks like the beige white diet, but that's all that they can manage. You've then got sort of the oral motor dysfunction. So we're not able to chew certain foods. Like the fruits, veggies, and meats are often a flag that we can't actually chew more complex food textures. So you'll see children who are just unable to eat, or they'll only manage purees and only manage those meltable foods. Or we're seeing something in the pharyngeal phase where they're not able to protect their airway, or there's a slow response to the bolus time, or something happening in that phase. We then also have this group of children who they might not necessarily be presenting with a diagnosis of any form, or there might be sort of more a dyspraxia or a DCD underlying, but they have these general motor delays, strange coordination patterns and strength, and that is actually impacting their ability to coordinate food and coordinate the required skills that is needed for eating. So the feeding skill domain is quite complex, but I guess the main ones that we'll see is like the sensory processing challenges and the oral delays as well. And then we have the psychosocial dysfunction, which I kind of have a little giggle every time, because it kind of just says everything else or anything else that is contributing to the child's feeding challenge. So a lot of the time it is some of these mealtime behaviors that we're seeing, but how it all links together is sometimes it starts as a medical piece, which then sent those signs or gave the child those signs that, oh, food doesn't work for me. But then there was the sensory piece or a feeding skill deficit that meant that food still doesn't feel good. So that has kind of led to these behaviors. And in turn, it sort of supports that inappropriate caregiver management of trying to manage those behaviors. So we'll see children who are unable to eat around others, like they won't eat at school or preschool. They're either not able to sit with the family for meal times and eat, or if they do, it has to be with a device in a certain chair facing a certain way. There has to be bribes, threats, rewards, something for after the meal to get them to actually eat, because there's either no interoception and no drive to do it on their own, or they just will only eat under these set circumstances. We then also will see children who are refusing to eat what's on offer or refuse to eat at all. And the big part here is the increase in caregiver stress. That's how we know it's significant, and it's more than, which we'll get into as well, it's more than just fussy eating or more than just a picky eater, is when that caregiver stress is so significant and you can see the impact on the relationship with the child and the caregiver happening at mealtimes and around food, which obviously then extends to other areas as well. For the psychosocial piece, there's also a huge population of children who have gone through some form of trauma. So either a medical trauma or a developmental trauma, or a trauma where the food was what was used as part of the trauma, be it forced or restricted. So that, as we know, with trauma, it can change the brain chemistry and everything there. So there's this group where there's children who have been through trauma, so they can't trust food anymore. So they will restrict and limit their foods so that it feels safe for them. So these 4 domains are what we're looking for when we're assessing for pediatric feeding disorder. But like I say, there technically only has to be one covered, but usually you can see how they all come into each other quite quickly. Now we've got so pediatric feeding disorder was 2021 when it became an official diagnosis, but before that, I think 2013 or so, we had ARFID, which was avoidant restrictive food intake disorder. These are quite different, but there hasn't been a lot of awareness or recognition of the differences or what the differences are. And I think sometimes parents, they will Google that their child has a feeding challenge and it just pops up with ARFID. So they panic immediately and think that it's, start kind of treating it as ARFID straight away. But there is a huge gap in that knowledge space because they are very different. So ARFID is obviously a mental health diagnosis. It fits with 2 of the domains of pediatric feeding disorder. So it often fits with the nutritional piece, but also the psychosocial piece. But for it to be ARFID alone and not pediatric feeding disorder, there has to be no evidence of medical complications or no feeding skill deficits, because essentially with ARFID, the recommended treatment for ARFID is more of a CBT kind of approach. But if the child is still having some medical complications, or if they still have a feeding skill deficit, no amount of CBT is going to solve or fix that problem. We have to address the medical and the feeding skill domains, which is where it gets a little bit tricky. But ARFID is essentially the child has developed a fear around food. So maybe they had a choking incident when they were little, or some allergies, or something happened around food, or sometimes there's nothing that happened around food and they just feel the intensities and the flavors of food more than others. So sometimes there's a reason and sometimes there's not, but there does need to be a clear difference between the 2. And the main one is there the medical piece, and is there the feeding skill deficit piece there as well? Because if it is, then it needs to be treated as pediatric feeding disorder. And I know sometimes down here in Canterbury, because we don't have sort of a clear pathway for ARFID, it often goes into the eating disorder treatment pathway, which again is different approaches. The child's going, well, I'm happy to eat these foods in these volumes, but it has nothing to do with body image. So ARFID, to meet the criteria for ARFID, there has to be no evidence that the child is restricting their food based on body image or perceptions of that. It's very confusing. There's lots of factors. But we then also have this group of fussy eaters, which again is different to pediatric feeding disorder, but can also very quickly become, fussy eating can become the pediatric feeding disorder if it's not managed well. So fussy eating is a typical stage of development. So we'll see 90% of toddlers in that 18 month to 3 year period. 90% of toddlers will go through a phase of fussy eating. It's just part of development. But when we need to start to be concerned about that is when that becomes longer than 3 to 6 months of that period of fussy eating, and the caregiver stress significantly heightens as well. With fussy eating compared to pediatric feeding disorder or ARFID, with fussy eating, yes, there's restricted foods. There's often fruits and veggies are a bit tricky. We'll only go for certain textures. There's, they can be just set in how they want their foods to be. But the difference is there's still some flexibilities. There's still, we can have it in a few different settings and foods can be served in different ways. And there's a little bit of flexibilities there. Whereas pediatric feeding disorder and ARFID, it has to be in the certain way, certain shape, certain texture, certain consistency for the child to actually feel safe enough to actually eat that food. So there's, I guess, not a huge amount of research as well in this space, but I guess fussy eating, the key is more than 3 or 6 months and the level of caregiver stress, it then becomes pediatric feeding disorder. Again, because pediatric feeding disorder is such it's a new diagnosis, we don't exactly have long-term outcomes, but we do know the outcomes, obviously, of malnutrition. So we know that obviously pediatric feeding disorder can lead to chronic malnutrition and deficiencies in macro or micronutrients if it's not managed appropriately. A lot of the times, because there's this medical piece, we see a lot of chronic health conditions that come alongside of this. So often some gastrointestinal, cardiorespiratory, endocrine, allergies, something else that comes alongside that. But then we also have the high chance of some neurodiversities that come up as well. I know particularly ARFID can be a bit of a flag for some neurodiversities or anxiety disorders. So there's a high chance of those coinciding. But we do know that children who are presenting with feeding challenges, we know that often it impacts their sleep, their toileting, their social skills, their general skill development, their quality of life, but also, I guess, the key part being the caregiver-child relationship and the general family dynamics, which are not the most important part, but a huge part that plays a role, because that level of caregiver stress, obviously, the more the caregiver stress, the more the child is going to get stressed, but then in turn, the more the child is stressed, the more the caregiver is going to get stressed. And that cycle just can be very hard to break and gets us in this terrible cycle of essentially pediatric feeding disorder just becoming worse and ongoing, and can lead to ARFID, can lead to other eating disorders, can lead to other diagnoses as well if it's not treated correctly. And so in terms of who can treat and what that process looks like, we're going back to that framework. So we need the medical team, we need the nutritional team, and we need the feeding skill team and the psychosocial team all to be working together. But we need the whole team to do the assessment process as well, because we've got this lovely diagnosis, but we don't have one set assessment process or assessment tool or assessment. There's kind of assessment criteria, but we don't have one set assessment that we're doing. So it's often questionnaires, interviews, and what we're seeing. And a lot of the time it's a speech therapist or an occupational therapist working in the feeding space who does that initial piece, and then we kind of refer on for more medical investigation or more feeding skill support or nutritional support as we need. So like I say, it's amazing that we've got this diagnosis, but we don't yet have a set assessment process or assessment tool, except for our team and the domains that we're looking at. So we tend to start with a OT or a speech therapist in that first part, but like I say, the key and the whole thing is we need a multidisciplinary team to be involved. So we need all of our appropriate medical professionals to cover that medical piece. We need our dietitians to cover the nutrition piece. We need our OTs and our speech therapists to work on the feeding skill. And we need our OTs, our psychologists, and our counsellors to do the psychosocial pieces. We really need everyone to be involved and on the same team for pediatric feeding disorder to be properly addressed and treated. And like I say, sometimes that can take a really long time and be a really long process, and sometimes it can be shorter. Basically, I want to leave you with a few questions to start to ponder what pediatric feeding disorder looks like in your service. Does your team know about pediatric feeding disorder? Do they know about the 4 domains? Do you have a current screening or assessment process for pediatric feeding disorder? What I would recommend is the Feeding Matters website. They are American-based because they just are kind of the leaders in this space, but they have lots of screening tools that you can start to implement if you need something quick and easy to go. Is this pediatric feeding disorder? Are they meeting the 4 domains? Is this something we need to address further, or is it just, a fussy eating or something that doesn't need as intense intervention? Who are the medical professionals and the health professionals that you need to be able to refer to? Are these internally, or do you need to externally refer to those professionals? And how can we basically increase awareness of this assessment process and this diagnosis? Because unfortunately, we can give this diagnosis, and it's something that we should start to do, but as of yet it doesn't change anything in terms of funding that's available. So a collective push to get that out there, to go, no, this is a serious medical condition that we need to address, and it needs to be the whole team, and it's not going to go away on its own. If we've got a child with these medical complications or with a feeding skill challenge, which is contributing to the nutrition and the psychosocial pieces, it's not going to go away on its own. And we need some intensive therapies or intensive work to kind of overcome these. I have a reference list, and I would actually recommend this one here, which is kind of our pediatric feeding disorder Bible, if you will, kind of covering all of the information on pediatric feeding disorder, what we need to know.
Awesome. Thank you so much, Rebecca. That's amazing. Really interesting. I think we've got a couple of minutes left, so we could, if anyone wants to put on their microphone and ask Rebecca a question, or pop one into the chat, then Rebecca will have a little minute for that. And I think Jane has just written in the chat about respiratory physiotherapists being involved in the medical management to support the progression from chronic cough to bronchiectasis. In the northern regional area, there's a Lungs for Life program that involves nursing, PTs, and SLTs.
Amazing.
Any thoughts about that?
Yeah, that's fantastic. I mean, I could have listed so many more medical and health professionals that we needed, but we kind of do need everyone to be involved. That's amazing that you've got that. It'll
be interesting to hear more about that next time, Jane.
Yeah, I would love to hear more. I'm not actually sure if it's something we've got down here, so it'd be
Yep.
Developed out of Counties Manukau, a program, research funding from the Paediatric Society to develop a program in the community of high flyer children coming to the ward with certain criteria about how frequently they came with chronic cough that were often to do with feeding difficulties, and got referred to community nursing follow-up, and then should they need a referral to community speechies and community physios as a way of preventing the awful progression onto Donna, it's Adrian. Adrian did the research, but feeding and so community nurses, speeches and physios as part of that. Sadly, funding for speeches and physios, but that's the program to prevent, hopefully to prevent bronchiectasis.
Fantastic. That's great.
So there's just a couple more comments. Crystal, interested to know your treatment pathway or process. And then there's just a comment from Emma that I'll read out now. So thank you for raising awareness. I completely agree, more discussion required about how it could be funded in the public health sector. Yeah. So maybe I guess you're working in mostly a private kind of pathway.
Yeah, I'm thinking of the treatment pathway question. That might need to be one for the
next time
follow up, because it's a complex one. Yeah. But it's kind of taking what you've assessed, what areas are impacted, and then that kind of guides your treatment
direction
pathway. But I know there's lots of research, because we do more sort of intensive or home-based one-on-one therapy, and that's kind of been what we've seen to be effective in more the physical domains, but obviously working alongside the medical and other domains as part of that treatment process. But I can't really answer that. It's individualized. Yeah.
Wonderful. So we try and run to time with lunch and learn, so people can move off with the rest of their workday. Thank you so much for this, Rebecca. It's been really interesting and really beautifully presented. And we look forward to seeing as many people as possible who can join with us in 1 month's time for a kind of a debrief and a thinking where to from here. Rebecca is hoping to be able to come to that, and I'm sure she's happy to get your questions and things, maybe make connection with her by email. If you Google her website, I'm sure you'll find her.
Yeah.
Wonderful. Thank you so much, everybody. Take care and see you in a month's time.
Awesome. Thank you so much.
Thank you.
Bye.